Good afternoon, everyone. So the Biochemical Society and Portland Press are pleased to welcome you to this webinar, which is part of our Biochemistry Focus webinar series. Topics in the series include different research areas in the molecular biosciences, as well as practical sessions to support career development. Each webinar will give you the opportunity to ask questions via text, and we welcome suggestions for future topics and speakers to feature in our webinar series. Please see the website for more details. So my name is Thailise Souza. I'm a postdoc at Azali Lab at University of Warwick. I'm also a member of the Society's Policy Advisory Panel. And I am very delighted to welcome everyone to today's webinar on antimicrobial resistance, the next pandemic. The Biochemical Society believes that molecular biosciences play a key role in addressing societal challenges, including the ones related to public health, and antimicrobial resistance is a pressing example of that, isn't it? Threatening to cause 10 million deaths by 2050 and to push 28 million people to poverty. The Society conducts policy works aiming to communicate the views of its community and members to policymakers. For that, the Policy Advisory Panel identifies matters of relevance to both the public and science sectors, and we recently made AMR a priority. It's a crucial moment for that, both at UK and international levels, as the new UK 5-year AMR National Action Plan is being developed, and the 2024 United Nations General Assembly Summit is fast approaching. Taking on this current policy climate, the Policy Advisory Panel updated the Biochemical Society's position statement on AMR, which was launched during the WHO's World Antimicrobial Awareness Week last year, and also published in this year's March issue of the Biochemist magazine, which is available to read online if you want. In this statement, we highlight the connection between AMR and molecular biosciences, the importance of a collaborative One Health approach for tackling the AMR threats, and the crucial need of innovation and new models of funding to maintain a pipeline of new antimicrobials. This antimicrobials pipeline is currently running dry, as only 12 new antibiotics have entered the market between 2017 and 2021. We also highlight the need for decisive political leadership and willingness to address the problem. This webinar will further discuss and explore these key themes, and it's now a great privilege to introduce our speakers, Professor Laura Piddock, Dr. Jim Jenks, and Baroness Natalie Bennett of Manor Castle. Before I hand it over to our first speaker, I would like to mention that questions will be asked at the end of the webinar, but please do send in your questions during the talks. If you have a question, please type it in the question box as it's showing in the screen there. You can see it there now, stating who your question is for, and we will try to answer as many as possible at the end. And our first invited speaker today is Professor Laura Piddock, Scientific Director of the Global Antibiotic Research and Development Partnership and Emeritus Professor at University of Birmingham. Laura has been at the forefront of antimicrobial research since her PhD, beginning her career in a hospital and successfully integrating this background with academic research. At Birmingham, Laura led a team researching bacterial multidrug efflux and transfer of drug-resistant plasmids, and discovery of efflux inhibitors, very important. Yeah, Laura joined the Global Antibiotic Research and Development Partnership, so short is GARDP, in January 2018 as Scientific Director, and leads the discovery and explanatory research and scientific affairs programs. She's also a member of GARDP Policy and Advocacy Group. So Laura, I hand it over to you now.
Thank you very much. I'm assuming you can all see my slides okay.
Yes.
So thank you for inviting me to talk today. So I'm going to talk about GARDP, a non-profit model of research and development of new antibiotics, and also talk about the outreach work that we do, connecting and supporting the antimicrobial R&D community. So it's clear that antibiotics are the foundation of modern medicine, and for many of us, particularly in high-income countries, it's almost impossible to imagine a world without them, and many of us would not have survived to adulthood. But antibiotic resistance is a major global threat, and there are numerous articles in the lay media as well as scientific and medical media about these issues, not just in the UK or Europe, but much further afield. The recent GRAM study, the Global Burden of Antimicrobial Resistance in 2019, showed very clearly the number of direct deaths were 1.27 million and associated deaths at just under 5 million. These are considered an underestimate because the data did lack that from some countries, but I understand that there'll be a new publication coming out soon, possibly this autumn, and the numbers have undoubtedly increased. So this is a very big burden globally. So although this is an old slide from the O'Neill AMR review of a few years ago, I think most people recognise that it's not unrealistic to consider that without new antibiotics, up to 10 million people a year could die of drug-resistant infections by 2050. But what this slide really shows is that the burden of people with drug-resistant infections, and really elaborated in the data in the GRAM study, I would encourage people to look at that article if they haven't already, is actually Africa and Asia. The numbers there are really quite dramatic, although that's not to minimise the numbers in Europe or other countries. But in parallel, there isn't a broken antibiotic pipeline. There simply aren't enough new antibiotics in development. And the World Health Organization estimated that only 2 to 5 of the 252 products in clinical development will actually make it into patients. But of course, not all new antibiotics get to all of those who need them. And I've quoted here a Ugandan HIV/AIDS researcher from 2000, and the same is true for new antibiotics. If we look at the left-hand side where antibiotic resistance is growing, you can see I've just given you an example here of carbapenems, which are considered very powerful last resort drugs, and 2 bacterial species, Acinetobacter baumannii and Klebsiella pneumoniae. And those are data for Europe. But if you look on the right-hand side, you can see where not all antibiotics are actually registered. Just draw your attention to the fact that the left-hand slide, the hot colours indicate the highest % resistance, whereas on the right-hand side, the cold colours indicate the highest number of drugs registered. So it's a little counterintuitive. But the take-home message is where there's the highest burden of resistance, they've got the least access to new antibiotics, let alone old antibiotics. So responding to this global health crisis, GARD-P was created by the World Health Organization, a Drugs for Neglected Diseases initiative in 2016. And in 2018, GARD-P was established as an independent foundation. We're a not-for-profit organisation with over 80 staff working globally, including North America, Australia, Southern Africa, Brazil, India, Japan, Kenya, and Malaysia. So we were established to address this public health failure, not a commercial failure. There are other activities to addressing that aspect. And the governance of a non-profit balances partnerships and perspectives for diverse sets of countries and partners. And our work is based on the disease burden and the human cost of drug-resistant infections. So our treatments are to address public health needs and not commercial viability. And access is particularly important to GARD-P, where they need to be available to those who are most affected. And GARD-P also obtains critical clinical data to support the optimal and appropriate use for those with the highest burden of disease. So our vision is that all infections are treatable for everyone everywhere. And our mission is to accelerate the development and access to treatments for drug-resistant infections. Now, I've been asked to cover very briefly our discovery research because that's likely to be of most interest to the people in this webinar, but I will touch on other aspects of our work as well as our outreach. So our discovery and exploratory research, it aims to address critical gaps in the global preclinical antibiotic pipeline. This means that we do a lot of horizon scanning activities to be clear on what those gaps are and those that we could fill. And our work focuses quite narrowly on the highest priority pathogens for which the WHO has indicated there's a need for new treatments. So our work focuses on novelty, and in particular where no other actor will be bridging the gap. And ultimately, we want candidate molecules with attributes in line with GARD-P's clinical development portfolio. So we're looking for agents from new chemical classes that target those that are either new targets or unrealized targets, such as those for which there are no drugs in current clinical use, and a new mode of action. And I think it goes without saying that any of our candidates should have no cross-resistance to any drugs in clinical use. This is our current portfolio from target assessment, hit identification, and validation to lead candidate. We divide it into these 5 areas. I don't have a lot of time today to go into these in any detail, but we've done activities in all of these, and we have an article coming out shortly on under-realized targets, which is a result of our horizon scanning. And this also fits in with our outreach activities that we want to support the community. And we have another resource, Antibiotic DB, which is a database of antibiotics, both undeveloped and those that are approved for human use. All of the other areas are laboratory-based projects with our various collaborators worldwide. And aligning to our programme, ultimately are candidates that would feed into the treatment of sepsis and sexually transmitted infections. So this is where we are today with our discovery programme. We've been fortunate to collaborate with numerous Japanese pharmaceutical companies who've shared proprietary libraries that have never before been screened for antibacterial activity. We screened over 136,000 compounds, and from these had 6 series of novel chemical entities, including 3 that are enhancing the activity of old drugs. We've built a network of global partners, and you can see on the dots on the map above where these are located. This is a little out of date because we now have 2 new partners in South America. So these are the 3 areas that we are working to address with our clinical development: sepsis in children and newborns, serious bacterial infections, and sexually transmitted infections. And it's in particular, our development is on late stage and then moving into access. So our development work, we have sponsored a phase 3 trial to evaluate soliflodacin as a treatment for gonorrhea. And this has been in partnership with Entasis, now Innoviva. We also have a partnership with Venatorix on their drugs, cefepime taniborbactam, a beta-lactam beta-lactamase inhibitor. We have signed an agreement with Shionogi and the Clinton Health Access Initiative to facilitate access to cefiderocol in 135 countries. In terms of the clinical work that we've been doing, we've completed a neo-observational study, which is on over 3,000 babies in 11 countries, to find out what infections they're suffering from and the types of drug resistances. And this has recently been published in PLOS Medicine. And we've launched the neonatal sepsis multinational trial to test various antibiotic combinations of old drugs to treat neonatal sepsis. We've also started an observational study on multi-drug resistant gram-negative bacteria, and we have open sites in India and Southern Africa. And as I've mentioned before, we've had this phase 3 trial on soliflodacin, and we completed enrolment of patients for that from 16 sites in 5 countries. And we anticipate giving the outcome of this trial this autumn. So moving now to our capturing knowledge and sharing, this outreach activity that we do. And if we look on the wheel on the left, you can see we do numerous activities. So why does an R&D organisation do outreach activity? Well, the simple answer is when GARD-P was set up, that everyone advising us was very, very concerned at the lack of companies and academic labs working on new drug development. And there was a real concern that not only were people exiting the field, but there would be a loss of expertise and technical know-how. So our Revive webinars and other activities seek to fill that gap. I'm going to go through some of these activities on the following slides very, very quickly for you. But we started our Revive webinars in June 2018, and you can see on the right-hand side that we have very great global reach. We also have a very large number of website hits every month, and this is because our resources, including the encyclopedia, library, and we'll be launching an R&D roadmap soon, are widely used by the community. So this is an example of some of the webinars that we've done, and it's important to emphasize that everything we do in this program, often under the Revive brand, is free of charge to anyone, anywhere in the world. All of our webinars are available on YouTube, and all of them remain available, because although the ones started in 2018 sound a little old, actually they're not out of date in content. So please do have a look. And just to indicate here that we sometimes do our webinars in collaboration with others, as shown here with one with INCATE and another with the TB Alliance. We organise various activities at conferences such as symposia, workshops and boot camps. Indeed, we've just had a symposium accepted for the 2024 ECCMID next year. We also have a joint conference with the British Society for Antimicrobial Chemotherapy and ourselves, and we do these each year, and they're completely online and again free of charge, and everything is recorded and accessible afterwards. We do these usually with 2 collaborating organisations. Last year it was 2 from India, the year before that was with Germany, this year 2 in Africa, and next year 2 in the Netherlands. And I do hope that you will sign up and join our conference. We also publish viewpoint articles. These are short comments and opinion articles with a wide range of topics, and I've just given an example of 3 here. Our Antimicrobial Encyclopedia is a resource that we want everybody to use, and we have a variety of terms that are added every single month. This is an example of what it looks like when you enter it on the left-hand side. And if you clicked on absorption, this is what you'd see on the right-hand side. And there's lots more information available to you should you want it. There are videos by some of our experts. There's an example of one from Dr. Jessica Blair from the University of Birmingham on efflux. The back end of this is this resource library. So there's an awful lot of information should you want it. We have an expert network. There's over 91. In fact, I was just told this morning we have another 5 that have just added. And these are actively contributing experts that help us develop all of our activities. And there's 81 that help promote our work. We also link in with scientific societies, partner organisations, and have collaborations around the world. If you want to get involved, do contact us. Love to hear from you, particularly about the encyclopedia. So thank you very much for listening. And on this slide are also listed those that have funded GARP or currently fund GARP. So thank you to those as well.
Thank you, Laura. Extremely informative talk. Amazing. Yeah. And now I'm pleased to introduce our second invited speaker, Dr. Tim Jinks. He's head of interventions for the infectious disease at Wellcome Trust. Tim leads Wellcome's work in advancing research and development for therapeutics and diagnostics, alongside research to support solutions for antimicrobial resistance. Prior to this, Tim designed and led Wellcome's strategic priority area for combating drug-resistant infections, and was responsible for a portfolio project supporting early-stage product development, covering therapeutics, diagnostics, and devices across several therapeutic areas. Previously, he has spent time in both academia and industry, with a decade of experience in industry in biologic therapeutic research and development, and most recently consultancy. So I hand it over to you, Tim, now.
Great, thank you very much. And it's my pleasure to be able to join the meeting today. And really fantastic to follow up Laura's presentation. You know, the important work that GARD-P is doing is something that we value. You'll see it also featured in my slides, and I'll be repeating some of the messages that Laura covered, but hopefully I will skip through some of those things and focus on some of the additional information I want to share with you today. So on the next slide, please. What we have here is, a real public health crisis. AMR is not a disease, but a biological phenomenon that is undermining the ability to treat infectious diseases. Our reliance on antibiotics and their effectiveness means that we're very much exposed to the loss of these treatments as resistance increases. So on the next slide, this is showing some of the data from the Graham report that Laura has already mentioned. And while the global burden is very significant, this is something that is actually twice what previous estimates had suggested it would be. There are some additional things that are important that we learned from this study, and that's the distribution of the burden of disease. Particularly important is in the green bars, you see the impact in Africa, and the rate of deaths from drug-resistant infections is highest in sub-Saharan Africa. And this is something that arguably would not be predicted, particularly when you consider the issues as relates to access and the inadequate supply of antibiotics to people in those regions. But on the next slide, what you see is that there are two regions in the world which suffer most as a consequence of resistance. So the highest amount of AMR burden is in Asia, the largest number of people who are suffering as a consequence of this, and is followed by the people in Africa. So in those two regions, this is a very real and serious crisis today, and one that urgently needs to be addressed. There are a number of interventions that are necessary to solve this problem, but one of the key things, of course, is the focus of today's discussions, and that's about new treatments and new antimicrobials. So I'll focus the rest of my talk on that, but I do want people to bear in mind that that's not the sole solution to controlling antimicrobial resistance and protecting people's lives against drug-resistant infections. But obviously, it's a fundamental tool in the toolkit. And we do have this issue that there is a crisis in the inadequate pipeline of new treatments coming along. So in the next slide, we did an analysis of the pipeline against the priority pathogens as listed by WHO. This was based on the pipeline in 2019. WHO itself has done subsequent analysis of the pipeline, and the pipeline numbers have improved. But one thing that's missing in their analysis is kind of a readout on how adequate is the pipeline today. So the WHO analysis does say that the pipeline is inadequate, but is a little bit gentler about giving an indication of that. So the analysis that we did was based on considering the probability of success given the stage of development. And what you can see in the far right of the slide is in most cases, the pipeline is woefully inadequate to meet future needs. While there are candidates in the pipeline, and that's a very good thing, and there are more coming along, if things go as they historically have done, it's not likely that we'll get the necessary drugs that are needed. So the take-home message here is we have a pipeline, it's beginning to improve, but it is far, far short of what the public health needs are for the future. Next slide. So if we look at the situation, of course, I just told you that the pipeline is too weak, but it's fundamentally unsustainable. And this is a result of a number of factors, and there are externalities here that are important to bear in mind. I mean, the science is difficult, but this isn't just a science problem. So what we have are issues that relate to the commercial landscape for these products. And antibiotics are commercially unattractive. And what that has resulted in is the exit of major pharmaceutical companies who historically have provided the products mostly for most of the world and completely exited this space. Following on that, the small and medium-sized companies where most of the innovation has been occurring in the last 2 decades also are not able to succeed in this space, even if they are successful in bringing forward a candidate into licensure. So they result in bankruptcies. So what we have now is a very small number of companies, of the major multinational companies, who are still involved in or interested in this space, that are complemented by a number of innovators who have very poor prospects for their commercial viability. And that creates problems for sustainability in the pipeline, and it actually reads back into the system of how do we support the R&D to bring the candidates forward in the first place. In addition to that, Laura pointed out this issue as relates to capabilities. And globally, we have significantly diminished capabilities to do the R&D, from discovery through development to bring forward a product candidate to make it available as a drug. And this is a significant problem that has to be addressed if we're going to have a sustainable pipeline and sustainable antibiotics for the future. Next slide. So I just wanted to share one point around the economic aspects and the commercial factors, because ultimately this can't be separated from the bigger issue, and how do you address the public health needs? And the fact is that antibiotics are commercially unattractive for investment. And this creates a problem in supporting the R&D pipelines. So the analysis here shows the difference between, at the top, what the expected profitability and return on cancer treatments are, versus at the very bottom, what can be expected on antibiotics, which is actually a loss. And the economic situation of this is what's informing why major pharmaceutical companies have exited the space and are actually not looking to do significant investment for antibiotics for the future. So this economic problem, this broken marketplace issue, reads across and has very significant impact on weakening the R&D ecosystem for new antibiotics. Next slide, please. So there have been a number of interventions that have been identified and deployed to address this weak pipeline issue. But there's still much more action that is needed on that. A lot has been done around push funding, and you've heard about the very important, great work of GARD-P in this space. They are effectively functioning in that space related to push funding. Alongside that are other players such as the Repair Impact Fund, AMR Action Fund, which Wellcome is a participant in, and BARDA in the work that they do in the broad spectrum antimicrobials program. CARB-X is another engine that provides push funding in this space that Wellcome set up and continues to fund. So I'm going to talk a little bit more later about both CARB-X and the AMR Action Fund. Alongside that are some vehicles that improve how clinical trials are done, lowering the barriers as relates to the effectiveness and cost of conducting the clinical trials, and hopefully creating better studies that support licensure and appropriate labels for the new drugs. In that, Advance ID is a clinical trial network that Wellcome has established based in Southeast Asia. A third area relates to regulatory reform. The regulatory pathway for new products, and particularly those that are highly innovative, is not as smooth as it could be. So there are opportunities for regulatory reform that can accelerate the licensure of promising new drugs. And lastly is the issue that's related to improved reimbursement. Ultimately, we have a very significant problem in how these drugs get paid for, if they can receive an appropriate payment to cover the cost both of R&D as well as staying in the marketplace. There has been great progress on this front, particularly led by England and NHS England, with the model that is often described as the Netflix model for payment. That model has created a new way to pay for drugs that delinks the payment of those drugs from the amount of usage. And this is a very, very handy thing because it achieves two things. First of all, it's a predictable payment for the drugs that are supplied to the NHS. It also means that the drugs and the profitability is not linked to bulk sales, and therefore improves how stewardship can be achieved. So that's something where NHS England and that system has really led the way in the world, and is now moving it beyond the pilot phase, which is fantastic. The United States has adopted some change related to the CMS system, which is how the federal government sets payment for drugs, but it's not really achieved enough change so that the procurement there is improved as much as it should be. The government of Sweden has deployed a new model, and that's one that offers some improvements, but again, is not sufficiently adequate overall. But a number of the other G7 countries are looking at procurement models that can hopefully address this significant commercial failure that is badly impacting the sustainability of the pipeline as a whole. Next slide. So what I want to do now is briefly talk to you about the key areas where Wellcome has been funding product development related to antibiotics. So CARB-X and AMR Action Fund are two vehicles that support R&D, and between the two of them, starting from drug discovery right through to licensure. Alongside that is the Advanced ID Clinical Trial Network. And at the bottom, I wanted to mention two projects that we're supporting related to access and procurement, because ultimately these are also very, very important features. So there's work that's ongoing at the Center for Global Development looking at the procurement mechanisms for the world. And they are trying to determine the best way that access and stewardship can be achieved and sustainable supplies for all countries in the world. And they've come out with some papers to propose that there should be something of a grand bargain between richer countries and poorer countries that can achieve that. Alongside that, GARD-P has a project that is called the Secure Project, which is in partnership with WHO and the Clinton Health Association and UNICEF. And it is aimed to achieve very similar aims as the CGD project, but is actually about the real world procurement mechanism and instrument for supplying drugs to the countries. So what we are hoping is that between those two pieces, we can start addressing these issues that are limiting or preventing the supply of much needed antibiotics to low and middle income countries in the world. And therefore we can overcome the access barriers, as well as making sure that people can have access to the appropriate drug for treating the infections they have, rather than no drug or inappropriate drugs. Next slide. So CARB-X was founded in 2016 and it's a joint partnership between Wellcome, BARDA, NIH, NIAID, and Boston University. It was set up to be a product accelerator for new drugs, vaccines, and diagnostic products for AMR. The principal pipeline of CARB-X is heavily weighted toward antibiotics. And so it has positioned itself as a key player in this R&D chain from discovery through to licensure. CARB-X itself, it runs open funding calls. It's just finished up the 2023 calls, So future funding calls are not yet announced, but it selects from the open funding calls the most promising project candidates to fund and support. Those projects can start from the early stage of R&D for candidate identification and selection through the first in human trials, or the first phase 1. An important feature of CARB-X is that it's not just a funding instrument, but it provides technical as well as business support to each and every project based on the needs of those projects. This is something that we, together with BARDA, felt was critically important and missing for these product developers, because quite often we are talking about very small startup companies and ones that don't have the full breadth of skills and capabilities accessible that a major pharma company would have. So part of CARB-X's job is to help fill that gap based on identifying the needs and bringing in the skills and capabilities to complement whatever each product developer may have. CARB-X has now been running for several years. It's just moved into its second phase very recently. But up to this point in time, it's invested now, it's over $400 million and just about to cross the 100th project supported in its portfolio overall. Very important to us, as well as to our other funding partners, is that it's fully international in what it does, both in terms of accepting projects as well as in the way that it works. So it has a network, the Global Accelerator Network, that extends from the US through Europe and into India. On the next slide, we just briefly touch on the portfolio of antibiotic products, and this is showing the alignment to the WHO priority pathogens, but not mostly by syndrome rather than the specific bacteria itself. But what you can see is that there is a good distribution and good coverage for many of the principal serious syndromes that are impacted by drug-resistant infection. But in some areas, there's pretty significant weakness still overall. CARB-X isn't intended to be the whole pipeline. It is intended to play a major role overall. So we count this as a success. But what it does show you is that there is some ways to go when you take a global perspective on the world's needs as a whole. Next slide, I want to talk about the AMR Action Fund. And this is a vehicle that works somewhat differently than CARB-X. It was established by the pharmaceutical industry in partnership with Wellcome, WHO, and the European Investment Bank. And the AMR Action Fund is a venture capital fund, but it has a social responsibility attached to the way that it does its investments. It's utilizing over $1 billion in funds and is aiming to launch 2 to 4 new antimicrobials within the next decade. So that is the goal of AMR Action Fund. The investment space that they are working in is from late phase 1 through to licensure. That's the sweet spot for investment that they should make. And it's not just antibiotics that the AMR Action Fund might invest in. On the exceptional case, AMR Action Fund can also invest in diagnostic tools that can either achieve significant change in the development of new antimicrobials, or work kind of like a companion diagnostic tool, or in itself can change the landscape overall for the treatment of patients. One aspect of the AMR Action Fund that is important is that they have a role relating to advocacy and are intended to bring increased focus to the issues in this space facing drug product developers. So this is a significant role that they have, unlike most any other venture capital fund, and they have a policy and advocacy group attached to AMR Action Fund that are active in North America and Europe principally, but also work across India and Japan in the work that they do. On the next slide, it just briefly touches on the existing portfolio of the AMR Action Fund as it stands today. They've made 5 investments. You'll see that the first one listed there is Venatorix. That's one that Laura mentioned. So this is something where we have a very nice alignment of partnerships, but because Wellcome was an early funder of Venatorix, Carbaxis funded Venatorix, we have AMR Action Fund coming in as a venture investor, and there's a partnership with GARD-P. So this is something where the R&D ecosystem of new interventions is actually coming together to work in a positive way overall. The AMR Action Fund, though, in addition to Venatorix, has 4 other companies they've invested in, three of which are for treatments. One's a phage product treatment. The other is a microbiome type product. So they're highly diverse approaches to addressing new treatments. And that's an important thing underlying their mission, is that they should seek to stimulate diversity in approaches and drive forward on approaches that are beyond traditional targets and traditional small molecule approaches. Pattern is a diagnostic company, so that fulfills that exceptional case here. And very soon we would expect an announcement of the 6th and 7th investments made by AMR Action Fund. So they've gotten off to a very good start 2 years into their mission. Next slide, I just want to touch on Advanced ID. This is the clinical trial network that we established that is based in Southeast Asia, stretching across the South Asia. There is a hub that is the coordinating center for Advanced ID that is based in Singapore. It is directed by Professor David Patterson with his co-director of Dr. Mo Yin. The purpose of Advanced ID is to be able to conduct registrational studies in a region where there is a very large pool of patients that are relevant to AMR. And so far, we've gotten to the point of establishing the network. The first study has been launched. That's called Acorn HAI, and that's really an observational study that's looking at surveillance focus in healthcare-associated infections. This is to get the systems up and running, but across multiple sites in multiple countries. They've had great success getting started there. There's over 35 sites in, I believe, more than 17 countries. First patient was enrolled in August last year, and now there are several hundred patients into that study. So that's gotten off to a good start. That has been followed by a trial that is called the RAPID trial. It's one that is supported by the companies bioMérieux and Pfizer. And what that is doing is testing the impact of rapid diagnostic testing and facilitating early directed antibiotic therapy. So this is going to be a very interesting study that can show the role of using diagnostic tools as well as managed antibiotic choice care on patient outcomes. Soon, we are hoping to see Advanced ID moving to a clinical trial for a candidate drug. So this is something that Wellcome's considering right now, and basically watch this space to see what can happen. But the important thing about Advanced ID is that this can provide capabilities that can increase the throughput of drug development and hopefully provide higher quality data around the effectiveness of new antibiotics against drug-resistant infections themselves. It's been a particular barrier for some drugs in the recent past. So the next slide, I just want to finish on the point of where are we and what are the challenges we face. So we have progress overall on the pipeline. In terms of preclinical to clinical research, there have been a number of interventions and funding mechanisms brought forward to improve the state of play. It's far from perfect, but it is certainly not a disaster case. But as we move down the pipeline and consider the state of affairs approaching registration and on market, actually there is still quite a significant problem. And the greatest barriers right now and the greatest obstacles are actually concentrated downstream and related to the late stages of development and moving forward, once drugs become registered, moving forward to making those available as global products. And this is something that requires further attention. It is not a scientific problem nor a research problem, but sadly it is one that has consequences on the feedback into the sustainability of the pipeline overall, because these downstream barriers are actually preventing private investment coming forward to support the pipeline. So I want to leave it here with this two-part message on the state of play, that things are improving in many respects. We have good promise in the rejuvenation of the pipeline early on, but we need much work done downstream so that there can be sustainability as these candidates come forward, and for those that are successfully registered, that they can become products and products made available throughout the world wherever patients need them. So final slide, I just want to stop and thank you.
Thank you so much, Tim. It was really amazing. And now I'm going to introduce our third speaker and last speaker of the day, Baroness Natalie Bennett of Manor Castle, Green Party peer and secretary to All-Party Parliamentary Group on Antibiotics. Natalie was leader of the Green Party of England and Wales from 2012 to 2016 and was appointed to the House of Lords in 2019. She has academic background in agricultural science, Asian studies, and mass communication, and started her career in journalism, going on to work for many leading publications. She has been a champion of many different policy issues, ranging from the UN Sustainable Development Goals to the rights of asylum seekers and sex workers. As secretary to the All-Party Parliamentary Group on Antibiotics, she raises the profile of antibiotic resistance, the need to preserve antibiotics, as well as the lack of new treatments for bacterial infections, and helps accelerate discovery effort. It's with you now, Natalie. Thanks.
Thank you very much, and it's lovely to be with everyone this afternoon. And I'm very aware that time's tight, so I'm going to pack in as much as I possibly can. But I just want to reflect for a second on the title of our webinar and a couple of things to think about. The next pandemic, I think if we look at Laura's figures for the deaths and deaths associated around the world, I would suggest there's a very strong argument to say that it's already a pandemic now. And the other thing is to look at that overall title and ask ourselves the question, as at the moment lots of people are asking about the climate emergency given the state of the Northern Hemisphere and the state of our oceans. How much do we scare people and how much do we look at constructive ways forwards? Things to think about afterwards, perhaps. Next slide, please. Okay. We've already had mention of this, and I'm going to talk mostly about the UK context, but I think the illustrations I'm going to provide very much reflect what pretty well happens in other countries. And 2014, Professor Dame Sally Davies absolutely got the ear of David Cameron, now then Prime Minister, and we got a big speech made. Now, I think it's worth saying that lots of scientists, perhaps who often haven't studied a great deal of sociology, economics, politics, often might think, great, we've got a government that really gets it now. But there's something called in journalism, in politics, the grid. And that meant the grid for that day said, right, we're talking about health, we're talking about superbugs. The next day, the grid moves on to something else. And there's no guarantee you'll get any output at all. However, next slide, please. We did, in this case, get a real output from this. We got the 5-year National Action Plan. And I often hear government ministers claiming that the UK is world leading. And in this case, it's actually true. I think it would be fair to say at that point in 2019, others have moved on perhaps further since, but there was a real point. But what's very clear is that even what's in that strategy is nothing like enough. Next slide, please. So where I come into this story is in October 2019, I entered the House of Lords. We then had, after a month, we had an election, and then a couple of months later, we had a COVID pandemic start. So it was all a pretty strange period. But one of the first bills that I seriously worked on was the Medicines and Medical Devices Bill. And I hadn't intended to do a great deal on this. There's only 3 Green Party members across both houses. We cover a great deal of territory. And I was really intending to do a bit of work with Baroness Cumberledge on women's issues in medicine, working on the Medicines and Medical Devices Bill. But with that scientific background, which is something I bring to politics that sadly very few politicians have a scientific background. And I'd urge anyone who's thinking about listening to this and thinking about maybe I should go into politics, please do, because we desperately need more people from a scientific background. What I did was I put down an amendment. It was a very simple amendment. I took what the government, what this bill said. Bill, of course, is what something is before it becomes an act, before it becomes law. I said to the government, what you say about the environmental impacts of veterinary medicines, and that comes about because there's some awareness that veterinary medicines are a problem on the environment. You should apply the same rules to human medicines and indeed to medical devices to think about what impact they're having on the world. People tend to focus just on this one patient, but what kind of society, what kind of environment are we creating with the drugs and the way we're using them? So next slide, please. This is a demonstration of how not to do things in the House of Lords. You'll remember that I was quite new, and I got very frustrated when we got to the stage about voting on this bill, because this modest little amendment that I had, and I talked to quite a few people from the industry about it, which made the same kind of environmental considerations for human medicines and medical devices as for animal ones. I got a government whip, effectively in this context, the junior minister reading out the response from the civil service. That junior whip has now gone on to be our Treasury Minister. She is indeed a very capable woman, but science is not her special subject. And I got very frustrated that the government wasn't taking, as I saw it, antimicrobial resistance and the much broader impacts about pharmaceuticals' impact on the environment seriously, and I called a snap vote. And actually, that's not too bad, considering in terms of, I was very pleased, quite a few crossbenchers, non-party people, and a handful of Labour and Lib Dem people who perhaps knew something about the issue and could see where I was coming from, voted with me. But because there wasn't a Lib Dem or a Labour whip to abstain, and there was a government whip automatically to vote against any opposition amendment, I lost the vote. Next slide, please. And so, but that did help to put me on the radar. And then I had, through King's College London, I had an intern, some of you may know, Paul Ongerong-Fady, came to me for a year, funded 1 day a week as a final year PhD student from KCL. And that then drew me into working with the British Society for Antimicrobial Chemotherapy. And so for the past year, we're just finishing now, I've had 2 interns, Jules and Emily, who've been working with me with some outputs to come through later. And we've really been looking at how we can really raise this issue up the agenda. And it's not just us. Next slide, please. This is just happens to be in 1 week in the House of Lords. These were 2 of the events that I hosted, one of which came through investigative journalism, some truly horrific figures. It's well worth, if you haven't seen this, looking up this research, which came through SOAS and was publicised on Channel 4, among others. About the use of AMR in particularly pig farming in Poland, and the figures are absolutely horrific. I haven't got time to go into it now, but well worth looking into. The same week, and with a much more global focus, a whole lot of NGOs, campaign groups, people like the Brook, we call something else now, but we used to be Send a Cow, Ripples, it's called now. They got together and I was able to host a meeting room, and people from around all of these sectors, all these organisations got together and talked about animal health, some horrific figures on what lack of animal health provision there is in Ethiopia and Pakistan in that report. I would recommend looking it up. Next slide, please. But I also, as a Green, I see this in a much broader context. What we are doing is trashing the planet and creating a deeply unhealthy society. So the same week, actually, I was also speaking at a roundtable launching this report, which looked at the way in which pesticides and climate, and that comes from the Pesticides Action Network. And again, if you look them up, you would find more about that. Starting to acknowledge that we have an unhealthy planet, unhealthy people, the whole One Health perspective, the planetary health perspective, all of these things are slowly starting to enter our political dialogue. Next slide, please. And my way of thinking about the AMR issue is that it's part of a much bigger issue in terms of the impacts of pharmaceuticals on our own health and environmental health. But that's also part of what most pharmaceuticals are. AMR, they may not exactly be novel entities in the sense that they're discovered often from organisms or in the environment, but we take them out and spray them around in far, far different contexts from those in which they're discovered. This is what's known as novel entities. I say pesticides, pharmaceuticals, and plastics for shorthand. And the details are all there. Research in 2022, which showed we've exceeded the planet's boundaries, the capacity to deal with all of these things we're bombarding our natural systems with. Next slide, please. And this is part, for me, of a whole part of a bigger story. I've just been having a debate on Twitter this afternoon. We talk a lot about climate. We sort of talk about nature. We're starting to talk about nature. We talk very little about biogeochemical flows. But what we ultimately have to move towards is a human society, a healthy human society that lives within the physical limits of this one fragile planet. Something that looks also at the human needs of this is what's known as donut economics, an author called Kate Raworth. Well worth looking up if you haven't heard of her. Next slide, please. Then finally, coming back to my two interns, what we put out just in the last week of Parliament before Parliament rose was this report. And there's a link down in the bottom left if you want to find where this report is. This was my interns, Paul Longeron, Fady, my office collectively, with a huge support from lots of experts and the industry, talking about what's going to be done, what should be done. But that message that I want to really share is lots of people who aren't in their day job, what they fully do most of the time is not politics. They're scientists by and large, and researchers, etc. They got involved, got engaged, and that's one of the reasons why I'm seeing I'm going to have some more, and at least one more BSAC intern. I'm going to have a King's College London intern, people who are doing PhDs increasingly, and I think rightly, are saying, how can I know that I learn these things, but how do we actually make sure they get delivered into policy, get understood in politics? And I'm afraid that the only way that's going to happen is if you get involved yourself. So I'm just going to finish looking at the time with just one final slide, which is to note that what I've got coming out is a book that tries to bring all of these things I've just whipped through together. I can guarantee to you it's the only politics book that you're likely to read in which AMR and broader issues of pharmaceuticals and public health will have an absolutely central place. And what I would say is that we're focused a lot today on discovering new drugs, and of course we have to do that, but we have to stop destroying the old ones with factory farming. We have to think about how do we create a far healthier society where we actually need many less drugs. And I'm sure many people on this webinar have thought about that, but really we need to consider all of this as a package, the One Health, the planetary health, the public health perspective. Thanks very much.
Thank you very much, Natalie. It was really good to know more about what the government is doing on AMR. And now I would like to welcome questions from anyone in our audience. So if you have a question, please type it in the question box as shown now in the image on the screen, so you can see it in the slides. So if you want to type in. So I'll start with one question. I think it is for both Tim and Laura. So the question is, there still appears to be a gap. The step before CARB-X and GARD-EP, EDS, the translation of discovery science, molecular biology and bacterial physiology studies that have identified potential novel drug targets, to preclinical clinical drug candidates that CARB-X, GARD-EP ready, that are CARB-X, GARD-EP ready. It seems to me that the right desire for new targets to antibiotics won't be realized until this gap is addressed. Any comments from Laura and Tim?
So if I understand the question correctly, is, how do you bridge the gap from potential new targets to actually getting new antibacterials into preclinical development and beyond? Well, the way you bridge that is making sure that you're aware of what these potential targets are and that they are actually potentially druggable. And this is actually the premise behind the article that we've written that is in late stage revisions now for a good journal. So hopefully that will be answered in detail soon. But the reality is it's not just finding an essential gene in a bacterium that could be a new target. The product of it is not just finding an assay in a lab that you can find inhibitors for, is making sure that those inhibitors could form the basis of a new drug. And there's quite a lot to translate that. And you're right, I don't think, in my opinion, there is sufficient interlinking of those two areas. And indeed, a report led by REACT a few months ago, and the DIATO one came out only a few weeks ago on their website, talks about where, how to bridge that gap. GARD-EP is an R&D organization. There are organizations that, national and international, who fund basic research, but who's funding the linking between the two? And that's a real question that should be addressed.
And I'll just add that indeed this is a gap that we do recognize at Wellcome. It's one that in a way it's opened up as a consequence. It's an unintended consequence of the way that many funding instruments and mechanisms work. There is a separation between basic research, discovery research, and translational research or product development that can make the translation across these two spaces not well covered by existing grant and funding mechanisms. So it is something that we are looking at Wellcome to determine if there's something that we might do differently to address that issue. But I do want to reinforce one of Laura's points here, and that is that there also needs to be a change in the thinking and understanding about translation across from identifying potential targets toward bona fide drug development R&D. And there is a bit of a knowledge gap there that somewhat it is unhelpful in this space. And we need to actually kind of break down that knowledge gap by the transfer of information and knowledge from product developers to people that are in the discovery sciences so they can better understand what kind of research could position things to be addressing that translational gap. Thank you.
Thank you. Yeah, so the next question is, what are some ways we can get involved in government scientific policy as PhD students? So I think it's for Natalie. Are there any other intern openings? I am currently part of the policy network within the Biochemical Society, but would love to do more.
Hey, well, I think in terms of BSAC, I'm pretty sure the applications this year have closed, but I know that there's a number of other learned societies who are really looking to this. And I think one of the things you can do is perhaps also to equip yourself for this is you should be able to get on the list and keep an eye out for what the All-Party Parliamentary Group on antibiotics is doing. All-Party Parliamentary Groups, the members are peers and MPs who are focused on that issue, but people can simply attend their events and find out more, and often there's a Zoom option these days as well. But there's also a question of look around in your local area where you're studying and see what might you be able to do to perhaps link up with the local head of public health in your local council if you're thinking about it in a UK context. context, look around to see how you can just find out what's happening, how you can learn how to understand how all these things work. I think we're going to see, and I hope we're going to see a lot more of these kind of internships and a lot more formal roles. But you can do lots of things informally that will actually often give you a route through to finding new ways of doing things. So it doesn't have to be formal, but keep your eye out for formal things and particularly follow the learned societies, I think. Thanks.
Thank you, Natalie. Yeah, so one more question. How does antifungal resistance compare to antibacterial resistance in terms of importance, issues, and research into new solutions? So it's open to all speakers, this question.
If I can jump in first, because this is a pet one of mine, as you said in the introduction, agricultural science is my first degree, and I've got absolutely fascinated by soils and the place of fungi in soils, but also the kind of damage we're doing with antifungals. I mean, I visited one of McDonald's star rapeseed growers in the depths of the Lincolnshire Fens, and I saw his array of his chemical shed, and there was basically one wall of antifungals, and he was putting out onto those fields, a blend of half a dozen antifungals at a time, spraying every 3 days. And many of those same antifungals are actually are used in human medicine. I think this is a huge area in which there's almost no public or political understanding at the moment. I'm actually trying to put in an application, I don't know if I'll succeed, but a special committee for the House of Lords to look at the relationship between humans and fungi, because I think this is something that politics really urgently needs to inform itself about, and that's one way of trying to do that. Thanks.
Thank you.
I can pick up on that a little more, because it's well recognised in the medical community that fungal infections, particularly in very vulnerable patients, including those in ICUs, are devastating and have very high mortality. And antifungal resistance has become increasingly problematic in a variety of different countries, and especially during and after COVID in certain countries where climate change is impacting on the types of infections that people are getting as well. So I think it's well recognised that antifungal resistance is an issue, sometimes to azoles, which are the class of compounds that Natalie just mentioned. We see azole resistance in human infections too. So this is something that everyone is concerned about in terms of quantifying it, just like antibacterial resistance. It's infection specific and country specific, but it is an increasing problem and should not be ignored.
Thank you very much. Yeah, so another question. A lot of research funding appears to be for late-stage drug candidates. What funding sources do the panel suggest for academics or small biotechnology companies? I think it's open to everyone as well.
Well, I'll jump in first if I may, because I want to point people toward CARB-X for the early stage research. Well, I actually would disagree about the availability of funding that's available downstream. It's a very significant problem for late stage products because it's highly costly and there's not adequate funds there. But nonetheless, the situation is improving. So CARB-X is a good place to look. I think that we will soon hear an announcement coming from a European, or well, it's an international funding body that will also support early stage product development that will be open to many international researchers.
If I can just mention that I was a couple of weeks ago at the John Innes Institute in Norwich for the summer meeting of the ABX network, which is the Discovery researchers, and they're planning on bidding for UKRI money to actually sort of strengthen that network and really look at that discovery end. So anyone, if you don't know about that, definitely look up ABX network and see what they're doing, and they're certainly looking to build Britain's strength in this area.
Right, so we have 2 more questions, I think, if there is time. So not much was said about educating the world population on how to slow resistance. Finishing course only take for correct bacteria, disposing, I think, not use antibiotic at pharmacies, don't use for prevention, especially in livestock. Is there much science communication work being done about this worldwide?
Oh, I can pick up on that. So I think it's important to note that, again, different regions of the world do different things. So in Europe, for instance, the use of antibiotics for growth promotion was stopped many years ago, nearly 20 years ago. In fact, over 20 for some European countries. And over-the-counter use of antibiotics, just selling them, is very, very restricted in many countries. But in others, it isn't. And it's not that this is inappropriate, and you'll sometimes hear that phrase. Sometimes it's the only way patients can access antibiotics. So it's a much broader societal issue than saying you mustn't be able to buy them at a pharmacy, because what that could mean is a sick child, for instance, is not able to be given an antibiotic, whether it's appropriate for that infection or otherwise. So yeah, this is something that the World Health Organization is looking into and has been looking into. It's part of national action plans, and it often comes under the heading stewardship.
And if I can just add to that, there's often a lot of focus on individual people are doing the wrong thing. But if you take, for the example, the All-Party Parliamentary Group on Antibiotics and the APPG on WASH, looking at the provision of basic water, sinks, etc., in lots of the global south, and particularly maternity wards. And we heard the most horrific accounts of where countries where only 20 or 30% of maternity clinics have running water. Now, often, as soon as a woman comes in, in labour or about to start labour, she's given a prophylactic antibiotic because there's such a risk of infection spreading in that environment. The answer is to tackle the system. I talked about we need a healthier society. We need all of those public health, basic environmental measures. It's not to say that we shouldn't do that educative job, but we also don't want people to die because they were scared off antibiotics when they did actually need antibiotics, even if the way in which they're getting those antibiotics is less than ideal.
Yeah, I think it's important to recognise that antibiotics should really be the last stage of dealing with infections. We need prevention, control, and treatment. And, if we can't prevent and we can't control, then we have to treat. And that's really where we are in many parts of the world.
Thank you. Yeah. So the last question is directed to Laura. So where do you see bacterial vaccines playing into alleviating AMR in high-risk countries?
So that's a good question. Really follows on from the last point I made. So where it's possible to make a vaccine and it's shown to be effective and safe, then I think that's a really good way forward. For instance, vaccines against typhoid would have a huge impact, and there have been extensive research over many decades to that aim. But we have to recognise you can't always vaccinate against all bacterial infections. That's what we've been talking about today. So they have a very valuable and great contribution to make, and there is a lot of research on this at the moment.
Okay, so yeah, I would like to thank everyone for joining us for this webinar, and thanks our speakers especially. So thank you, Laura, thank you, Tim, thank you, Natalie, for the enlightening talks. And we can continue this conversation online, so follow at BiochemSoc and at PP Publishing on Twitter. We welcome, as I said before, suggestions for future topics and speakers to feature in this Biochemistry Focus webinar series. So if you have an idea for a webinar in 2023, we invite you to submit a proposal for an upcoming webinar. You can find more information about the webinars, propose your webinar, and watch previous recordings on www.biochemistry.org/events and training. And all of our upcoming webinars are listed on our website as well. And if you have missed any of the 60+ webinars that we've already run as part of the series, or if you would like to watch them again, please visit the website or the Biochemical Society YouTube channel. So the details are on the screen now. And this recording from today's webinar will also be available to watch within the next couple of weeks. Join us on the 31st of July at 2 p.m. British Summer Time for the next webinar, Insights into the Role of Ribosomal Proteins in Development, when our invited speakers will be discussing ribosomal protein paralogs in germline development and how aging-associated long non-coding RNA1 prolongs chronological lifespan. And finally, I want to highlight that it's more important than ever to stay connected, and we discuss it today, and engage with your fellow molecular bioscientists. Join the Biochemical Society's community of researchers and specialists and take advantage of key benefits, including discounted registration fees for society training courses like R for biochemists and Practical Python for beginners. Those are very useful, and exclusive access to a wide range of grants and bursaries. You can visit the website to find out more. And that's it. Thank you very much, everyone, and have a nice afternoon. Goodbye.